According to the World Health Organization, the goal of universal health coverage is to ensure that all people obtain the health services they need without suffering financial hardship when paying for them. Universal health coverage is a continuation of the Millennium Development Goals and offers flexibility for countries to determine what will help them reach their health goals. It also means that people will not go through the pain of making catastrophic financial decisions to access health care. The depth and breadth of universal health coverage, however, is still a subject of discussion and debate globally. What it means in real terms, what does it take to implement, how it translates into benefits at population level, and how it can be measured. For Uganda, universal health coverage means health facilities being accessible in terms of distance and road network. It means having enough health workers at health facilities at all times. It equally means having access to health information and advice and being empowered to make decisions related to one's health. Universal health coverage for a country like Uganda means availability of essential drugs, technologies and supplies, access to emergency care and ambulance service. Broadly, it means access to food and a balanced diet, access to clean drinking water, access to quality education and good roads.
There should be at least health service providers to give health to the community members, and it should entail every community member who needs the service and not barring others, and also the distance they travel should be reduced. So in this there could have been maybe a maximum of 5 kilometers for somebody to go for distance than just somebody walking for a distance more than that, which becomes.
Therefore, universal health coverage is not entirely a health issue. To achieve it, it requires inter- and intra-sectoral collaboration, each sector stakeholder understanding their roles and responsibilities and how they can work together to create and achieve a shared vision. To promote universal health coverage in Uganda, the following efforts have been made: training programs, recruitment support by partners, financing, infrastructural development, ICT mobile health, abolition of user fees, and the VHT concept. Despite the initial efforts for universal health coverage, there are still gaps evident in the health sector. These include limited capacity for policy analysis at Makerere University School of Public Health and other institutions of higher education, as well as research organizations, increasing costs of a variety of health technologies in a context of restricted fiscal space for health programs, increased but less flexible financing for a small set of health programs, for example, HIV, malaria and TB, with potential distortion of sector priorities in other vital areas of public health. High rate of population growth not matched with growth in the economy and service provision. Mass media that are increasingly harsh to frontline health practitioners despite their powerlessness to cause change without upstream market systems.
We're still far from having well-renovated and functional infrastructure. We've built many health center floors, renovated many hospitals, but a lot remain to be functional. Many hospitals also remain unrepaired. So every place we've made progress, there is also a lot to really finish the job. We've recruited health workers, but we still have many health workers who are not trained on the payroll. We have many slots that are empty, and we are also beginning to lose many health workers going to other countries. So we really need to work on how to pay those that are in the system and how to make it attractive for people to choose to be health workers in this country. If you look at medicine, we've increased the budgets, but the budgets are still covering about have at least 40% gaps in medicines. So what I'm saying is that although we've made improvement, the needs of this country are still requiring that we do more.
Supporting policy engagements for evidence-based decisions, SPEED proposes the following. Strengthen the capacity of Makerere School of Public Health faculty through hands-on studies, fellowship and mentorship interventions. Provide support to policymakers through provision of evidence in program identification, solution identification and monitoring of performance of policies. Create policy engagement platforms and coalitions to stakeholders for shared vision and problem solving and holding each other accountable for the common goal.
One of the SPEED is here to achieve 3 objectives. One is to help the university, Makerere University, to benefit from new competences in doing policy analysis and policy advising. The second point is for us also to help decision makers, whether it's government or it is communities or civil society or NGOs, to learn what is actually happening once a policy has been passed or has been in effect for some time. We would like all these activities to be around how, as a country, develop policies and monitor them to achieve universal coverage. So all these activities should be feeding into supporting government to achieve universal coverage. We've actually been privileged to get funding from European Union to the tune of €3,100,000 for 5 years to do this work. European Union came up with a call, or what we call a grant opportunity, in 2013, towards the end of the year. And their main objective was to support schools of public health in Africa and other developing countries to try and generate capacity for policy analysis and policy advising to governments. So this grant or call was put out, and as the Makerere University, we responded to it, as many others. And in that we got the award. We have a partnership of 6 institutions. Makerere is one. The other Ugandan institutions include Makerere Economic Policy Research Center, which specializes in macroeconomics. We also have the National Planning Authority, which is a government agency that deals with the national plans. We also have the National Uganda Health Consumers Organization. This is an organization that deals with advocacy, particularly trying to raise awareness, but also influence decision makers. We are working with the 2 international universities. One from South Africa is the Human Science Research Council, based in Pretoria. Then we have the Institute of Tropical Medicine, which is based in Antwerp, in Belgium. This is an organization we've worked with for many years. They are going to continue to work with us in this particular work. Again, they are going to bring health systems strength.
From SPEED interventions, the following benefits are expected.
5 years after SPEED, we believe we will have left a legacy in 3 main areas. One is the university that has strong capability and competence to generate policy advice that is based on strong evidence. And the second part is that evidence should be able to be packaged in a manner that government and stakeholders can understand. And thirdly, capacity to actually bring feedback from the field of how policies are working, bring that back to the table. Maybe the third element is that we will have helped government to come to a manner that share common vision and work around or across boundaries, because generally governments tend to work within their ministries, develop plans. Even right now you have a National Planning Authority, but somehow the approach to ministry budgets year to year seem to be very much silo-based. So we hope that we will have brought this working across boundaries, working across sectors, and having a common vision. All of them developing their plan knowing that they are